Make a slight change to our agenda this morning, as Jane's train has been a bit late and we want to load her slides up properly. So we're going to take questions now, have a slightly earlier coffee break, and then start Jane's talk after the coffee break, so we keep a logical sequence of the talks and we've got time to get the slides on. So I'm going to join my colleagues.
My husband was diagnosed with CML after one of those incidents that sent him into hospital. And as I know with many men, they don't like going to hospital, they don't like going to the doctors. And it could well have been one of those things that got ignored. In his case, it was the fact that his hand suddenly swelled up massively, and after being told or nagged, he did go to the hospital and was subsequently diagnosed. But from what you've shown up there regarding the fish testing techniques, should there be an annual test available for most people to see whether they do in fact have CML?
I think, unfortunately, screening programs in the UK are designed to pick up diseases that are a little bit more common in the population than CML. And as we heard earlier, there's only about 750 new cases picked up in the country per year, so that would be an awful lot of fish tests done to pick up a very small number of patients with CML. And we'd also have to, although it's more common in people as they hit their sort of midlife, it can happen in children. Where would we start? It's probably not cost effective for the government to introduce a programme of screening the whole population for CML, and I suspect that financial implications will be a factor, and also our cytogenetic labs would be swamped. Unfortunately, even the fish test is fairly specialist, and they wouldn't really have the capacity to actually screen the whole population. At the moment, unfortunately.
I sort of expected that answer.
Yeah.
It seems sort of fairly straightforward to be able to identify. And for me personally, if my husband hadn't gone to hospital that time.
I mean, a straightforward blood count picks up many patients, which is a lot cheaper and more widely available.
Yeah.
So I think, and I think, most GP surgeries do health checks in people over a certain age every few years, don't they? So some patients do certainly get picked up that way.
Well, it's just from my perspective, it seems so brilliant the way that it's relatively easily treated. And it's about awareness, I think, as much as anything, because that simple blood test could be the thing that changes somebody's life.
Yeah.
Thank you.
Mm-hmm.
Yes. We'll pass the microphone across to you.
We know that the Philadelphia chromosome is the 22 with a bit of 9 on it, and we know what effect that has. But what effect does the 9 chromosome with a bit of 22 on it have on your system? Is it relevant?
I think it isn't relevant because genes are read in a certain way. So you have to have something called an open reading frame for the gene to be read and produce a protein. And the way that, amazingly, BCR and ABL joined together does result in the gene being able to be read and produced into a protein. But my understanding is that the other way around, it's not read. So it doesn't produce a protein that has any harmful effect on the cells.
So the 9 is just the odd 9 chromosome doesn't have any effect.
Don't think it has. As my understanding is, it doesn't have a significant effect and cause any problem for the cell because no protein results.
Right.
In the video that you showed of Roman Reigns,
Yes.
he talked about
Yes.
And one of the slides also mentioned it, thank you. Is that a term, is remission a term that you use for CML? And if it is, at what point for patients taking imatinib would you be considered to be in remission?
So remission is a word that we use very regularly, meaning that we've got good control of the leukemia, and it's sitting at various levels. So I use, as we've seen about the depths of response, the phrase hematological remission, meaning that the blood count is normal, the blood looks normal under the microscope, and then cytogenetic remission to mean that we would no longer be able to detect the Philadelphia chromosome if we looked in the bone marrow, and then ultimately major molecular remission to mean that we're down at these lower levels where we know the disease is much more safely controlled. I think remission is used quite widely within cancer to mean you've had treatment and you're in a good place. Broadly speaking, that's the meaning. But not perhaps necessarily cured. I think that's where the word remission sits. So I think that's a useful place for a lot of CML monitoring to call it remission. We're starting to move towards trying to think about a term of cure, perhaps more, what we'd say, a sort of operational cure where somebody may be well and without medication. But we don't yet have the knowledge to be able to say long term, are these people definitely cured and that they will never need medication again. So we have to be a little bit wary of the word cure, and hence remission is the word we tend to use.
Thanks. It's a question that we get asked, particularly with, taking out travel insurance,
yes,
where they ask
yes.
a question and it's a yes/no,
Yes.
tick box.
Yeah, I think,
and it's not
yeah.
a straightforward answer, is it?
It never is, and I think insurance companies are getting a bit better now. There are so many successful survivors of all sorts of cancers that I think they are getting better at assessing terms like remission. But unfortunately, what often ticks their boxes is for people to say, I've finished my treatment, geared perhaps more towards other cancers. So for CML, when you may well still be on treatment but in remission,
Yeah.
it can be a headache for insurance for sure. Yeah.
Thank you.
You've got a gentleman in the middle there.
Just a quick thought on generics. Yes, chemically they should be the same. I wonder if there's anything can be done about the general packaging of them, because, for example, Mylan is twice the volume of Novartis. Sandoz produced the Novartis one. It's no longer supported by NICE because they won't reduce the price. So we're on to other things which are either massive, they taste foul, or the pharmacy is actually issuing them virtually out of date.
Yeah, I mean, I think that's a difficult one for me to tackle because the generics are made by so many different companies. But I do absolutely appreciate what you're saying, that if only we could get it's not necessarily the actual imatinib, it's the way it's packaged, get that changed. That would really make a big difference. I agree. Absolutely.
And I think as a working group, I think we need to raise awareness of this issue, and as patient groups, I think, also have a very important voice in raising this issue. It is about funding, it is about negotiating a good price for supply, but it has to be acceptable, and the number of switches that have been coming through in the last year, I think, is unacceptable. And it must be unnerving to have a different colour packet, a different colour pill, sometimes it's a capsule. It's not ideal, and I think we ideally need to try and see what we can do to improve on the situation for long-term therapy taking. We've had quite a few people in clinic also asking about Brexit and the impact that could have on tablet delivery, and we've been assured that there's been a certain amount of stock being prepared in this context, but we are asked not to overprescribe for our individual patients, as that would just cause such a problem. But of course we don't know when or if that's going to happen, but it adds another level of uncertainty that we really don't need.
On the remission cure question, do you have any understanding of what has actually happened when somebody, as in my case, no longer appears to need the medication because it remains sort of stable at a very low level without it. Do you think that the drug has itself affected a long-term response that doesn't need constant reinforcement? Or is it that one's own immune system has somehow recovered in the period when the medication has been keeping it under control?
I think either of those are possibilities. We'll be hearing a lot more about this afternoon from Richard. I think certainly in people that have a low level of BCR-ABL still detectable by the most sensitive tests, may well be a role of the immune system in keeping that tapped down. And that's a very active area of research, because we really want to know why that works for some people and not others when they stop therapy. But equally, eradicating CML should ideally be about eradicating the leukemic stem cells, or the drivers sat behind the CML right from the very beginning. And ultimately what we would like are drugs that can eradicate that source and truly cure the condition, rather than relying on the immune system to keep it dampened down. I think at the moment it's a mixed picture, and I think different patients, drug-free, are there for potentially slightly different reasons. Okay, sorry, another question in front of you there.
Yes, I have a question. So you shared a slide earlier where there should be in terms of the PCR at 3 months, 6 months and 12 months. So what about if you are not exactly where we should be based on what you have shared, and in the long term also? And the second question about the way we live after we have been diagnosed and we are having one TKI, and doesn't mean that we need to work less, etc., and how it impacts on the treatment effectiveness.
Sorry, the first part of the question was if you're not quite hitting the optimal goals. I mean, that happens quite often, that patients' response may be a little bit slower than what is thought to be optimal, but they haven't, the treatment hasn't completely failed to work. It's somewhere in the middle. So those patients need to be followed very carefully, and we need to make sure that we monitor them very closely, make sure that they don't miss any tests, make sure that they're taking their tablets properly, then the tablets are being absorbed. There's no reason why the tablets are not working properly. Sometimes it'll go from a suboptimal response to an optimal response. It's just a question of time. And we don't usually switch therapies straight away or do anything. It may be time to do a mutation screen just to make sure that there's no other reason why the treatment's not working as well as we would like. And if the treatment, if the next time point it's still not meeting where it should be, and it meets one of those categories where we say the treatment has failed, then that definitely a switch in therapy should be considered. Sometimes people stay on the warning for quite a long time, and I think it's then a discussion between the individual patient and their consultant to decide whether a change in treatment would be a good idea to try to get to the optimal response. Certainly some patients, after a period of time on the warning, not quite as good as they should be, a treatment change may be implemented. I didn't quite catch the second half of your question, sorry.
Second question was more about, if we continue our life the same way as before we knew that we have CML, and same like working full time, etc., and then has an impact or not how the treatment works in the body, or should we work less?
Oh, I don't think there is any evidence that your lifestyle or what you're doing is going to impact on the ability of the treatment to work. The vast majority of my patients carry on working. They may be off work for a couple of weeks at the beginning of their diagnosis, but most patients do go back to work, and we don't advocate a reduction in working hours or a different lifestyle. We hope the aim of our treatment is for patients to live normal lives and do all the things that they were doing before. And there's no real evidence that working too hard, if that's which many people do, interferes with the way the treatment works. So we don't really tell people to live their lives differently.
It's about listening to how you
feel.
and
So
that
the
is
side
so
effects may,
different person to
yes,
person.
it does. The side effects
And-
may make you
yeah.
feel you can't work as much, but that's
Yes.
sometimes the case. But
And of course, it depends on your job and
Yeah.
what you do.
Yeah.
So many people, especially to begin with, curtail work or take time off work until they're adjusting to the medication. And it's important that employers are understanding about that. But
and of
it's-
course, to
yeah.
come to the clinic appointments is essential as well, to have
Yes.
some time
Yeah.
off.
So I would like to call a halt there. We can have any further questions at the end of the day as well. I'd like us to have a coffee break now, and perhaps if we could start again at 25 to, then we've got time to fit Jane's talk in at the beginning of the next session. So if we have a 15-minute break now, there's coffee and tea back upstairs again. I'd like to thank our speakers very much from this morning.